Good afternoon. As people join us, I'm Professor Ian Hick, Co-Director of Health and Policy at the Brain and Mind Centre of the University of Sydney. And I'm joined by my partner in life and my colleague in developing this youth model.
I'm Associate Professor Elizabeth Scott. I am the Director of the Young Adult Mental Health Service at St Vincent's Private Hospital in Sydney, and also a researcher at the University of Sydney.
This is the first in a series of educational webinars that we are running that will be available to be studied and to be followed on an ongoing basis, attached to our particular references in these areas that we'd like to go through. You'll notice also that there is a chat function down the bottom if you want to collect questions along the way and comments or request further materials from us. We are very happy to support that particular function and be in contact with you or others, or send us the contacts of others who you think may be relevant to this particular area. In this first lecture, we will overview the really important concepts that have driven us into the development of this specific enhanced model. You'll see in the title that it actually has two really important elements. The attempt to be highly personalized. It's not diagnostic. It's not traditional. It isn't about anxiety versus mood disorders versus psychosis versus borderline versus eating disorder or any other of the nomenclatures that we have. It's aimed to be a clinical model that supports highly personalized and highly skilled care. It has a second concept built in, which is measurement-based care. Elizabeth and I debate who's the world's best psychiatrist, but clearly she is. But even the world's best psychiatrist isn't that great at predicting at the start who'll get better, who'll respond to treatment, what will happen. What we are good at is tracking people over time. I make the comment all the time that I don't care how you got better. I really care if you don't get better or if you get worse. And as quickly as we can recognize that whatever we've recommended did not work, we'll respond to try and find a better treatment. That we're in a fundamental partnership with young people over time with complex disorders to get better outcomes is our goal. And that requires us to monitor in partnership with young people, often with their family, often with others, their response to treatment, or importantly, their non-response or their deterioration to get better models. As we start this series, I would like to acknowledge the traditional owners of the lands on which the University of Sydney has its principal campus, the Gadigal people of the Eora Nation, who for generations have lived on that land and transferred knowledge to us. One of the most important things I might say in that context is of the traditional owners of Australia, and owners being a funny concept. I'm not sure it's one that many Aboriginal people themselves use to own the land. But the important kind of concept brought to us for Aboriginal people is that of social and emotional well-being, which is a poor translation of the fact that we all live within social, family and community contexts, and our well-being is as much a function of us as a group as it is of us as individuals. I'd also like to recognise those who have lived experience of mental ill health, of suicidal behaviour and of its consequences, and the many people who have not received adequate care, and particularly in this context, the many young people who've never received adequate care for their significant mental health problems. As we move on now, the model itself, what we want to cover is really what is the significance of mental ill health in young people and why intervening at this particular stage in the developmental cycle is so fundamental to adult outcomes. I was just making the comment in another lecture earlier in the day, when I was younger, I used to do a lot in relation to geriatric psychiatry, late life depression. As I've got older, not that Elizabeth's got any older as we've done these particular things, we've become more and more interested in younger people. The early intervention movement in Australia has been fundamental in trying to intervene earlier, to stop people going on to 20 or 30 years of intractable mood disorder, of complex mental health morbidity, of complications, of chronic illness, of ruined lives and of ruined potential. And the challenge is actually to change courses for better lives. Clearly, as I just alluded to in the introduction, when you move into this area, you move into an area of great uncertainty. It's not for those who like boxes and categories. If you're one of those people who wants to put somebody in the anxiety box or the specific anxiety disorder box or the OCD box or the eating disorder box or the schizophrenia box, it's probably not in a great area in which to work. Many of those categorical systems were normalized or standardized on adults who may have had 15, 20, 30 years of those disorders and then taken back into adolescence. Most of the work in this area is how hard it is to know in a diagnostic sense, or even to fit those categories well to young people to present. That's not really the challenge. The challenge is to work with young people to try and actually understand how symptom complexes come together to create complex syndromes, which we may then attempt to manage for productive outcomes. So what we've been about, really the clinical work led by Liz over the last 15 years, has been to develop a better model of enhanced specialised care, a more personalised model, one that recognises the multidimensionality, that recognises people have what they have, the syndrome they have, and that requires smart, sophisticated clinicians working in multidisciplinary teams if we are ever to achieve these significant outcomes that need to be achieved. And in people's lives, that's not the same as clinical trials. It's not deciding one outcome beforehand, a reduction in depressive symptoms, an improvement in psychotic symptoms, a reduction in suicidality. It's actually about the complexity of people's lives. Not only the symptoms they have, the trajectories they're on, it's about their physical health. It's about their social health. It's about preventing going on to another medical condition, early cardiovascular disease, going on to disability, changing many courses concurrently. It demands a commitment to be engaged with the complexity of young people's lives and with their families and their schools and their educational and their employment systems. At the heart of what we are talking about is our favourite slogan, right care, first time. Much of what you'll hear and much of our experience in this area really relates to the fact that many of the young people that we've seen have gone through many systems on many occasions before they finally received the care that really should have been appropriate first time around. In the clinical staging models we're associated with, in many other models, it is very distressing to still see, and including in Australia, an unusual and I find impossible to explain commitment to late intervention, to not actually wanting to work with people early in the course to get them the care level they need at the first point they present to care, which has the greatest opportunity to then change the life course, maximise recovery, and go on to a productive life. If we go to the next slide.
Simple primary care doesn't allow room for personalised or targeted mental health interventions. Instead, it relies on one-size-fitting-all.
That's Sam Hockey, who along with me was a National Mental Health Commissioner some years ago. And Sam's experiences coming from the south coast of New South Wales and having to come, in fact, to Sydney and eventually through Liz's interventions and the interventions of others, received care that he would have never received, that a simple primary care model never met his needs and did not assist him to go on to the life that he particularly needed. So I'm going to say to Liz at this point, in your whole interaction with many of these people over 15 years, what do you think of that whole push it back to primary care model, that whole step care, try everything, and then eventually 3 or 4 or 5 years later, when it's much more complicated, then they get to see you?
I mean, I think it's very clear that the services that we have for young people in this country do not go anywhere near to meet their needs. And that's the needs for early intervention. It's the need for more kind of complex care and follow up over time. And I guess I see many young people who get through my door when they've had, they've been unwell for several years. They have high levels of disability. They've had high levels of risk, and they carry often high levels of very complicated physical comorbidity by that time. And some of these people are still teenagers, but they've been unwell for quite long periods of time. So clearly, if we were dealing with cancer or we were dealing with heart disease or diabetes, we would have absolutely failed these people at this stage. And I think also as practitioners, it becomes then very hard to treat people who have very established illnesses and are not necessarily as treatment responsive as they might have been at earlier stages of illness. So I think as a profession, it also creates a degree of nihilism that has really not been helpful. So the work that we've done in trying to intervene earlier, I think has been not only, I hope, will make progress towards a really different model of care in Australia and around the world. But also it is really refreshing clinically to work as a psychiatrist and as a clinician in this area and see what you can do with very small amounts of intervention at the right stage, at the right time.
You know, in the fields we're talking about, and what I love about working in mental health is this field actually with empathic people, people who engage, people who are deeply committed to the emotional life and productivity and the flourishing, particularly of young people. And they say all the time that they're listening. Often I wonder whether they are listening. What you'll hear and interspersed between the more technical and more mathematical and other academic work that I'll present in association with Liz is the voice of Sam, of Jess, of Rachel, of parents like Kathy, who you'll see later on, actually saying, is anyone listening? I've told this story 100 times. I've been sent back again to a system where my own needs are obviously much more complex. I think only yesterday, Liz was on a call that I was part of where a psychiatrist in the area was telling a family who's been through multiple levels of assessment that they should start again and go back and be reassessed again, as if all of the accumulated experience, which had previously not worked, not been brought to bear, simply would go back and re-diagnose and restart. I think the issue for us is that we are on a partnership and on a journey, and the sooner in a young person's life we can join that journey and actually make a meaningful difference and really work in partnership with young people and their families and provide them with the care that would be normal. I had the experience last night of joining with rheumatologists in Australia. Another early intervention paradigm that people may not be aware of, there's a really interesting one in rheumatology. When treatments have got better in that area through many of the new monoclonal antibodies, they want to turn inflammation off, not just down, off early in the course of illness to preserve joints, to preserve function. They now treat early in the illness, much like the virus of COVID-19 right now, to elimination, not just to turning the symptoms down a bit, not just to seeing they've done a little bit, not being an aspirin or an ibuprofen for a bit of distress, but actually to turning the illness process off. So another concept we're really trying to drive at here is, can we better understand the pathophysiology? Can we better understand what's really going on? And are we committed to turning these processes off, if that's possible, so that a person may have the most productive life? It's an interesting thing. I was just discussing with Pat McGorry just before we started, the extent to which a life associated and a life lost to mental illness is the same as a life damaged or lost to a virus, to a cancer, to a cardiovascular disease, to another inflammatory condition. I guess our commitment is to say it is, but it requires us to work with the same determination. And what we're really looking for here is clinical leadership, is clinicians who in everything they do are committed to the individual person that they see, but is using all of the available technology and methods. It's the 21st century to not just listen, but actually act in ways that are more likely to result in achieving those goals. If we go on to the next slide. So, the goal of early intervention is to turn it off, and we have been associated with new models of care. Often, and particularly in Australia, there's a kind of idea that early intervention doesn't have an empirical basis. In fact, Australia is the home of many of the biggest studies, and this is one we're personally very proud of, which Elizabeth led, Frank Fiafino has analysed, and we are the key group of following over 2,200 young people and watching what happens in their particular trajectories over time, and the extent to which actually the notion of staging is relevant. So one of the concepts we'll come back to, and just to mention here, but to take forward, is that of clinical staging. People are at different stages. That's not age. You can have a severe disorder and be 14, or you could be 19 or 20 and just have the onset of an anxiety disorder in the context of the current COVID-19 experience. But the stage of illness, as in many other illnesses, may relate to the style of intervention you need and the chance that you will progress. Obviously, one of the key issues here is to try and find those who have not yet developed the worst illnesses, but have a high probability of doing so and following that forward. So this is one of the key papers, and I just raise it at this point to say, while we will express many opinions in this area, and many remain the subject of ongoing evaluation, there is also a strong empirical base for many of the concepts that we are raising. In the next slide. What happens in these areas is a significant number of people who come under our care at the moment with the care that we provide, which frankly, for many people is extremely limited and short, will progress to more severe disorders. In our model of clinical stage 1A, that they are likely to go on. And those who've got lower functioning at baseline, those who've got manic-like experiences, psychotic-like experiences, my favourite one, sleep-wake cyclocircadian disturbance, are more likely to go on to worse illnesses. For the stage 1B, the so-called at-risk or attenuated syndromes, again, psychotic-like experiences and circadian disturbances are important. But so also are things like prior childhood disorders. You know, in the area, we're really interested in the progression from childhood disorders to teenage disorders and on to adulthood, on those developmental trajectories, those illness trajectories, and the way they intersect over these key periods of adolescent and early adult life. Again, this is part of the empirical justification for key interventions at this particular time. Next slide. One of the most important issues that we face here is a hard one for clinicians and services. Are we actually doing the job that we say that we're doing? We often see young people, they come in, they're distressed, they may be suicidal, they've sought care. And what we're good at through everything we do, what you might call the non-specific effects of engagement, just the simple presentations to care and engagement, is often reducing that distress and suicidality. But in work that we've been looking at, what is distressing is when you look at functional outcomes. Liz and I are the parents of a large number of children, and we'd like them to leave home and be functionally independent and take care of us in the future. That's the long-term goal of parenting. To do that, they need to function. What we see, and what we see in a lot of this work published, and now this is BMJ Open and larger cohorts out of that 2,500 to be published shortly, is in fact, as you see in the datagram here in the early work, only about a quarter reliably improve functionally over longer term follow-up up to 5 years. Sadly, although distress goes down, almost 2/3 don't really change. The level of functioning they had, which was often impaired at the time they arrived, stays impaired. This is really challenging for us. We have the idea that if we make symptoms go away, functioning will improve. Kids will go back to school. Kids will graduate to university. They'll go on to vocational training. They'll go on to independent relationships and lives. Is it true? I get asked every day of the week, why are you messing with the system? It's fine. We do a good job. We're engaging with people. We're nice. We're helping. Clearly people say they like seeing us. I go, yes, but what is actually the longer term outcome? Do you know what becomes of those people? I think in the young area, in the youth areas, there's an assumption, there always has been an assumption, that people will grow out of it, that they'll get better in some particular way. And a lot of the work on self-harm in this age group and others, they'll grow out of it. Meaning if they're still alive, they'll grow out of it. Actually, if people are functionally impaired at the time they present, that's often not the case. Now you see on this particular slide, there's one really interesting and tiny little line, a little green line, which goes from very functionally impaired from the bottom left right to the top right. That's the tiny number of people that Elizabeth takes care of who actually get very unwell and finally get to specialised care and get better. Liz, do you want to comment about those people? Because, you know, even the worst people in some ways are people you end up helping a great deal once you finally see them.
So I think one of the difficulties of coming into youth services is identifying very early on who is going to progress onto a more severe condition and therefore who requires more intensive treatment. And that does require quite a high degree of capacity for pattern recognition, to recognize not on the basis of diagnosis, but on the basis of the presentation of the young person, of their level of functioning, of their cognitive function, of their sleep and activity patterns, a whole range of different kind of markers that we can identify that tell us that those are the young people who are going to do poorly and require more intensive intervention. What is good to see is that if you put that into intensive intervention early, and that needs to be multimodal and it needs to be followed up over time, then you do see levels of function improve. And that includes young people with quite significant psychotic symptoms at presentation, high levels of suicidal ideation or very severe mood disorders, or disorders, comorbidity like OCD. So I think the good thing is if you identify people early, if you put intensive treatment, a bit like the analogy with leukemia, you identify those kids early and you put interventions in, they will do well and continue to function over time. That requires long-term tracking and this sense that this is, you know, these are longer-term issues that need to be dealt with.
Next slide. I think we might, oops. Okay. One of the issues about multidimensionality here, and one of the main concerns, of course, in our area, is actually dealing with self-harm and suicidality. So while many of the young people we see may or may not meet diagnostic thresholds, certainly in many services will not even meet the threshold for receiving a service and are easily discharged from services. In fact, self-harm is very common. What's interesting about the kids who present with self-harm and suicidal attempts, in this case, actually suicide attempts, if we follow them up over time, not only are they at increased risk of suicide attempts, which we followed, they're actually at increased risk of a whole lot of other important outcomes, like the onset of a bipolar disorder, of subsequent substance abuse, of poor functioning, of actually not being able to return to education, employment and training in the longer term. One of the issues for us is understanding beyond the simple, are you at risk, the complex. So picking up Liz's point about, for example, who we might be able to predict. This is where the research tells you things at times that you would not be aware of, or it might even be counterintuitive at times, and why continued systematic evaluation of these sets of young people is important. But of course, suicidality and self-harm is one of those constructs, along with the diagnostic and other issues that we must really aim for. There's been a lot of rhetoric, partly inherited from the American kind of concept of zero suicide in care, that we really are focused on self-harm. In truth, it hasn't received the attention it deserves. And the issue of keeping young people safe in this period so that they may progress to better lives is fundamentally tied up, not just in the treatment of their mental health problem, but in ensuring they actually do progress in and live long and productive lives. Next slide. We've got the next slide.
And better specialised care is totally important to me. Without it, I wouldn't be here today. And having that holistic approach to my mental health is life-changing.
So Liz, Jess, who was just shown, is one of those people that we've worked with over a long period, and we inherited from another service who basically had said to her, you're too complicated. You're too young. At a young age, you're too complicated to take care of. And has been, I can say, taken care of by Liz for the subsequent few years. I wonder if you can comment on that, Liz. When someone sees someone like Jess say, I wouldn't have been here without good care, do you reckon they really take that seriously? Or now they see her and they think, oh, no, that's not, of course she would have been here. Do you want to comment about just how exactly unwell Jess can be?
So I think one of the critical things to say is that Jess was taken care of by a team of people. And in order to kind of meet the needs of a young person, and when we first saw her, she was out of school. She hadn't been able to finish school. She hadn't been able to complete tertiary education. Her level of function was extremely poor. She had very chronic symptoms and she was still very young. And with multidisciplinary assessment and care, and she does show many of the systemic issues that we see in young people with complex mood disorders, including physical health problems, hormonal difficulties, sleep and activity problems, that with more intensive treatment and multidisciplinary care and support to return to education and work, she has thrived. Not only has she thrived, but she's now an advocate for other young people in the same situation. So certainly Jess and her family appreciate the specialized intervention that she's received. What their distress has been is that it's not available to all young people in similar circumstances, that it requires getting up to levels of very highly. This care should be available much more widely across Australia to the many number of young people who don't get anywhere near that type of intervention.
So I think it'd be fair to say, having met with Jess and her family on many occasions, if her family had not been connected, persistent, if her mother in particular had not continued to try and seek out better care, even though they had been to very reputable care previously, I don't think Jess would still be with us. I don't think she would be thriving. At her worst, she has a terribly severe, classically what would be seen as a mood disorder or bipolar depression type phenomena, and would not have survived. She had what we would call a late stage illness at an early age. Important thing as we talk about clinical staging is one of our key components. Because you're at a later stage, we will still work with you, but what you will require, even if you're young, may be more complex and may need to work in more intense multidisciplinary ways. Getting the right level of care at whatever stage of illness you're at whatever age. I guess what lies behind Liz and my own and our team's drive to make this more available is you shouldn't have to go through what Jess went through, what Sam went through, Rachel you meet later on, what Kathy and her daughters have been through, to find something like our service, which by accident or by opportunity you may be able to find, but actually it should be more widely available. Just like elsewhere, we try to make cancer care, cardiovascular care. Man of my age goes into an emergency department anywhere in the country. There's a fair chance with chest pain or a cardiac problem that he'll receive high quality care, or at least access to that high quality care. That's our goal. So to share our model more broadly, our description of our model is well summarised in the Medical Journal of Australia from late last year in Right Care First Time. And the circle you can see on the screen now, there are 4 key elements of highly personalised assessment, and then there are 3 key elements of measurement-based outcomes. And I just want to briefly name each at this stage, and we will return throughout this seminar series to more detailed assessment. Now, often we show this slide, people turn off and they go away. I can't do 7 things at the one time. I can only do 1 thing, or my service only does 1 thing. I can't hold a complicated concept like that. In fact, clinicians can, but what they need to be is supported by systems, organisational systems, the service they work for or with, and other issues which we'll return to continuously, 21st century technologies and smart systems to support them and young people and their families, in fact, to do that, as people require different levels of care at different phases or stages of their illness. But really, that's what we should be saying. People in other areas, in cancer care, in cardiovascular care, in rheumatological care, don't say they can just do 1 thing. They may be specialised in 1 thing. They may be specialised in a particular treatment or a particular assessment or a particular diagnostic, but actually they seek to bring those together to achieve optimal outcomes. So just to name these 7 elements. The first is multidimensional assessment. We need to assess young people in what we consider to be 5 key areas. Most importantly, we think, is actually their level of functioning. Can they actually live and function most effectively? With the previous Minister of Health, when I was trying to explain early intervention one day, she said, you mean you don't think you necessarily cure everyone? You mean someone will be able to go to work or school or function even if they had symptoms? And I said, exactly. And she said, oh, well, that's what you're talking about. I understand that entirely. Of course, and as you get older, you go to work every day with some symptoms of something or with some risk of something, but your functioning and your life is productive and your sense of well-being is high. So functioning for us is a key variable for young people, and having the opportunity for education, skills, training and functioning throughout this period is critical. If you drop off that during this phase of your life trajectories are much impaired. Second has to do with physical health. Health is health. Mental health and physical health is health. Many young people we see have concurrent physical health problems that are never attended to. Third is alcohol and drug use. My great friend Kathleen Merrikangas pointed out 30 years ago that if we treated anxiety and depression in early adolescence before the onset of alcohol and drug use, we'd reduce alcohol and drug use by approximately 50% in the wider society. We still haven't done it. One of the major complications, of course, when you see middle-aged people with mental health problems is their degree, particularly in men, of alcohol and substance abuse. Fourth, of course, is suicidality and self-harm. We've got to reduce suicidality and self-harm. And fifth is what we might call illness stage, illness progression, that which where psychiatry in particular wastes most of its life arguing about the diagnosis. But importantly, if we can stop illnesses earlier in their phase from progressing. So those 5 dimensions we suggest need to be properly assessed whenever a young person presents and then properly tracked over time. Clinical staging is a concept that we've developed particularly with Pat McGorry and Origin Youth Health. For those who are interested, we have a new book with Cambridge University Press, but borrows unapologetically from cancer, from cardiovascular disease, from rheumatology. Whatever the illness is, it has different stages. And earlier stages of intervention are aimed at twofold: actually stopping the symptoms that you have and preventing progression to a later stage, which would be have a more pathological impact overall. Again, interesting, so self-evident in other areas of medicine, still controversial in psychiatry, or at least psychiatry in Australia. I don't think so controversial increasingly elsewhere in the world. And I'd send people to the Lancet Commission recently on mental health see the extent to which clinical staging has been adopted as a fundamental part of frameworks for mental health problems and their treatment. Third is pathophysiological pathways. But although we say we're transdiagnostic and they're model syndromes, we're not saying there aren't certain systems, whether they're cortisol responsive systems, whether they're immune responsive systems, my personal favorite circadian systems, that actually may explain many of the syndromes that we see, but are not well characterized or captured by our current diagnostic systems. We work with 3 big ones: anxiety arousal, circadian, and neurodevelopmental. And we'll return to these because we think they can help to guide treatment selection in appropriate ways and have different treatment implications if you believe that's the underlying or driving pathophysiological mechanism behind that particular disorder. The fourth is actually understanding the developmental pathways. Independent of the illness a person has, at their age and stage of brain and social development, there are different factors taking place. Puberty, it's a big issue. So clearly hormonal development in early puberty and the onset of certain issues related to identity, cognition, affect, and effects of estrogen, etc. on brain systems, introduction of new rhythmic change, monthly cycles, fundamental changes, the social development, the mid-adolescence, peer relationships, exposure to alcohol and drugs, the social changes of leaving school and transitions in employment, what is happening at brain level in terms of white matter processes and development of pathways, development of actually regulatory pathways in late adolescence, frontal lobe development. There are many normative factors going on that may actually be corrupted or changed or be relevant to presentation. So understanding the stage of development that a young person is actually at is fundamental to understanding what the possibilities are. So at the front end of assessment, those 4 factors, not simple diagnosis, not simplistic biopsychosocial models. One of my favorite child psychiatrists, Peter Zatmari from Toronto in Canada, has a marvelous critique of the biopsychosocial, which he says is the nothing, nothing, nothing model. You just put everything in some category, but there's no integration. There's no real focus on what it is that is driving, that is relevant, that is the focus of intervention in a partnership between clinicians or services and young people and their families to actually getting to the heart of the matter to achieve the outcomes that are critical. On the measurement-based care, which is following people in care, there are 3 key concepts. One is real-time monitoring. If you aren't monitoring the outcome, the person doesn't know what is happening. If you only see them once every 6 weeks, or if you say to them, worse, come back if it doesn't get better, you don't know. You're not responding. The real life and real changes that are relevant here need to be closely watched. And as I said earlier on, our real interest is in the kids who do not respond, who deteriorate, and picking that up early. To do that well, in our view, in the 21st century is a whole lot simpler if you use the technology, if you use things that we all have in our hands and we have access to, and you use systems where real people can put in real data and in real time and you can respond. If Liz prescribed a medicine for you yesterday and it caused an adverse event today and you tell her now, she'll probably change it. She'll probably respond. Do you want to comment a little bit, Liz, on the extent to which actually in your own practice, this and the other things that we now have to use in the COVID-19 world have become central? That technology is a central part of your caring clinical practice?
So one of the things that has, I think, been dramatically changed the way we practice is the capacity to kind of track things in real time, to actually get people to provide information by email, by phone, through smart technology platforms that enable us to see where their mood is, so I see where my patient's mood is by them sending through their mood diaries to me. We keep in contact through other forms of technology, so I can see when things change and things shift so that I can intervene early. And that saves, in terms of efficiency, an enormous amount of time in being able to do things earlier rather than wait until symptoms or disability or syndromes are very much more entrenched and then harder to change. It allows young people to stay in school, stay in work, keep in universities without dropping out of these kind of essential things. So it does transform practice. It is very hard to get clinicians to take on these areas of change to do things differently from ways they have done it traditionally. And that is a major challenge for our profession.
I personally love it when I'm giving a marvelous explanation to people what is wrong with them and what I think should work, and having prescribed something terribly transformative, and they come back to me a month later and they say, Ian, it didn't work. What's your next trick? You know, that issue of actually really monitoring at the individual level what is really happening is a different way of seeing the world, and the accuracy and the timeframes in which that's picked up so that we can make very strategic changes in treatment paradigms as quickly as possible, we would argue is central and assistive, and makes clinicians' life easier, not harder, and empowers people to take a more active voice or more active part in their own care and to articulate those things which are of most concern to them or their family or others. The last component of the 7 is multidimensional outcomes. So having mentioned multidimensional assessment on the way in, you've got to track it over time. So if you think you've done a good job in reducing a symptom score by 50%, but the person has not gone back to school, the person's now got an alcohol problem, the person's just developed a physical health problem as well, have you really succeeded? Now, you can easily wash your hands of it and say, it was only my job to reduce the depressive symptoms. It was only my job to reduce the psychotic symptoms. Actually, I think you might find the odd, not terribly grateful patient, family, others, particularly if the medicine you prescribe that reduced the symptoms by 50% actually caused them a physical health problem and they're not going to continue with it. Or you're not really attending to those other particular issues, or you're not really concerned that the parents are telling you the kid's still self-harming and is suicidal, and you think it's a lot better, but they tell you it's not on an ongoing basis. So this issue of being able to track multiple outcomes and be aware of what is happening over time, because it gives a better picture of the things that are really salient to that young person and their family, is at the heart of tracking multidimensional outcomes. Smart systems allow you to see that. Smart dashboards, smart summaries. So rather than spending all your time asking what happened to in the last month, what happened in the last month to your sleep, what happened in the last month to your suicidality, how has things changed, you would know it at the time that you interact with people to decide its efficacy and where it might go next, or how it might be improved. So these are the big concepts that we're talking about. If we have the next slide. We didn't just make these things up. For all these particular areas that I've been discussing in terms of the 5 dimensions that we focused on: social and occupational functioning, self-harm, alcohol and substance abuse, physical health, and illness type, stage and trajectory, as you would expect in the academic world, we have quite a lot of publications, and Liz has led many of these publications. We've tracked young people over many years. We've examined each of these particular factors. Important to say, or sometimes people say to us, you appear to have not a focus on just one of them. Okay, well, no, because actually young people and their families and others expect us to be engaged with all. Very frustrating when people say to us, I don't do physical health. I don't do alcohol. Self-harm, that's the concern of others. I don't help with back to school, back to work. Liz, do you want to just comment on that multidisciplinary, multidimensionality, you know, for people who really get a benefit out of seeing us?
So I guess one of the good examples of that is the young adult unit at St Vincent's Hospital. When we set it up, the program that they developed there, the inpatient program, was really about symptom reduction. And it took a lot of persuasion and advocacy with young people and ourselves to say it was really not about symptom reduction. It was all very well if people's depressive symptoms reduced or their psychotic symptoms improved, but if they couldn't go back to school, or they couldn't get a job, or they couldn't live in their home and they had no social relationships, or they were not exercising and they couldn't sleep, then we really hadn't achieved anything. The person still couldn't function in their world. So it has changed the way we practice. and the way and the emphasis that we put on the interventions that we provide. So it does mean thinking very much differently about and listening to young people about what is it that they identify as being their biggest problem. If they can't go to sleep at night, they can't get up, and they can't go to work, or they can't go to school, or they can't concentrate. So this multidisciplinary, multimodal assessment means taking into account and giving weight to those different areas in the same way that you would to somebody's symptoms, and thinking about the specific intervention. So I say to the psychiatrists, the registrars that I trained, psychiatrists are like the conductors of the orchestra. We have to think about all of the different areas and how they work together and integrate that. We may not do it all ourselves, but we have to be the people that drive the system to provide the kind of care that people require to recover.
Okay, next slide. Okay, so this social and occupational functioning is a fascinating bidirectional issue itself. As I say, we don't get well to go to work, we go to work to get well. You don't go well to go to school, you go to school to get well. You go to education and training to stay well. It's so important to see the bidirectional relationship between a person's level of functioning, their capacity to regulate their sleep-wake cycle, their capacity to socially interact, their effect on cognition at any age of being socially engaged in purposeful activity on an ongoing basis. As I say, the real goal, and then this is where often I think psychiatry finds itself at loggerheads with many of the lived experience areas, the so-called recovery movements and everything else, is that actually it's about the quality of a person's life and their capacity to engage in purposeful activity. And the work that was involved previously with the National Commission, a meaningful life and a thriving community. You know that whatever the level of functioning you're at, it is purposeful and it's achieved. And there are many factors that influence that. But also being in a functional environment reduces suicidality, reduces substance use, promotes circadian function, reduces other opportunities for antisocial behaviour or for self-destructive behaviour. These are one of the big areas. And I think it is hard to explain to many outside the mental health field why we seem so little interested in that. I think one of the problems is we see people in the worst of their situations and we see the obvious symptomatic improvement. And a bit like surgeons who've, done the operation, we just assume they'll return to a high level of function or the functioning they came in at without actually seeing whether that's the case, without actually even necessarily understanding the cognitive, the contextual, other factors outside the illness itself that may actually be driving those particular factors. In most of the work I'm tied up with government and with economics and with why we should invest in mental health, that's the question. Is this kid going to get back to school, to education and a productive life? It might sound like hard economics. It's not really. I actually think it's incredibly empathic. That is actually the goal. That's actually what most young people say. I was taken to task by a young man I've been involved in self-treating a little while ago, been in our service for about 5 years. And I said to him, what is it you really want to do? And he was talking about going back to university. He'd never been to university, finished school, we want to go on to university, he was university age. And I sort of said, have we ever actually kind of focused on helping you to do that? And he said, no. I've seen the most marvelous people while I've been here, really empathic, lovely people, a lot about my childhood, a lot about my dysfunctional family, a lot about my intrapsychic pain, but nobody has really asked me what I really want to do, nor have they provided me with the assistance, the educational assistance, the pathways actually back in. Bit embarrassing when you go out and sort of talk about this stuff and you have trouble doing it in your own backyard. It's a big cognitive shift for us to put it up the front. But in this model, we do. Next slide. Okay, what we've been studying over longer periods, and we showed the earlier data here from the BMJ Open, this is the more significant data from a large number of over 2,000 people of social and occupational functioning at SOFAS scores over time. There's two things I'd like to emphasize here. Again, the bad bit and why we are so committed to change. Only 25% of the people who come into our services as they're currently constructed, which tend to be short episodes of care, psychologically heavy, symptom-focused, short-term, which make the terrible assumption that kids will grow out of it. Only about 25% achieve good or sustained social function over a 2-year period. And of those, about 2/3 already had it, so at least they didn't lose it. Of the other 75%, a significant number deteriorate or don't improve at all over time. I'd also like to emphasize in these graphs the variability over time. Care over time matters. Some deteriorate early, some deteriorate late, some are slow to improve and require care, and having taken time to improve, if that care is not sustained, they may well deteriorate again. Some come in at low levels of functioning, and we do not change that trajectory with our current brief intervention model. These are really challenging graphs for us. We're not happy about it. You know, if you look at cancer outcomes or you look at other outcomes this kind of way and said, really, you're only achieving a good outcome in 25%, and of those, actually 2/3 of that was actually the case that weren't in much trouble to start with. For those who are really in trouble, we have a long way to go. So the issue for us is occupational outcome, educational outcome really matters. From our point of view, there's a need to think about the models of care that might change these trajectories over time. But also we need to stick with kids over time. And I want to go into comment about that, Liz, about actually sticking with people over time who you know have complex illness pathways, so they can re-enter care, they can continue with care when they need to.
So I think the challenge for many services is the length of time of intervention. And we've been fortunate working with the University of Sydney and with some of the extended Headspace sites and now with St Vincent's that we can follow people up for longer periods of time. What will change that dramatically is if we can put in digital platforms that allow us to track people over time so that we can actually scale up the interventions that we have to larger numbers of people. It's very frustrating as a clinician to only be able to provide the types of intervention that we do to relatively small numbers of people, see good outcomes, but be not able to scale that up across the wider system. So I think we have the opportunity to do things differently, but if we're going to make a difference to young people, you have to stay with them over some of those key developmental transitions. Finish school, get your first job, go to university, deal with relationships, leave home, some of those really critical transitions where we know that people are much more likely to relapse or have a worsening or deterioration in their symptoms, and to able to provide the care they need.
There's been a question along the way about what about young people who don't have families or aren't still connected with families. That obviously is a terribly important question, and many young people you see have become dislocated from their families, disconnected through illness, through other factors, through social disadvantage, through traumatic upbringings. Clearly the health system is engaged. It does provide an important wraparound in many ways, and encouraging young people to become part of social systems again, social relationships again, even if they're not their family of origin, is a terribly important outcome in itself. And in fact, the SOFAS thing in terms of social and occupational function, the social bit, is about the establishment. We all need social networks. They may not be our family of origin. I often say to my own kids, forget the family, get better friends. You know, actually forming social relationships is critical at this age. So that is a big issue. I would say, however, it worries me in the youth and child area, a lot of family blaming goes on. You know, I see a lot of dads who are said to be the problem, or we see a lot of distressed families who are sent for family therapy because the family's distressed. And I often go, wouldn't you be distressed if your kid was actually self-harmed, suiciding, had a severe illness, was out of school? The distress is often a response to the problem, not the cause of the problem. It certainly needs to be dealt with in particular ways. But for those who are disconnected, staying connected with those young people through appropriate technologies, through joining with peer groups, through promoting social relationships is itself intrinsically important. And recognising those who have come from traumatic backgrounds or very disruptive social backgrounds is critical to long-term outcomes. Next slide. Just to say, in terms of the comorbidity issues, there are phenomena, there are syndromes that we are really interested in. Some of the ones that are really important to us include psychotic-like experiences, manic-like experiences, depressive symptoms, circadian disruption. These are some of the features, not the disorders, but the features that have high comorbidity. They overlap, they don't occur individually, but are likely to be highly productive. And these are areas that we will return to because they have different therapeutic implications. So we do recognise differences, but we also recognise the comorbidity, and that these things are not strongly coupled with specific diagnoses. Things like psychotic-like experiences occur across many diagnoses. Circadian disruption, which drives immune and metabolic disturbance, is not limited to those with bipolar disorder. And that in these other sets of experiences may well, therefore, be relevant to treatment selection and outcome without necessarily indicating a specific diagnosis. Next slide. We've actually looked in terms of our model, what do different people think and what do they prioritise? So the issue of trying to design a model of care that takes into account what do young people think, what do their families and carers think, what do clinicians think is important, and then what do policymakers and funders think is important. It's an interesting set of issues. So young people, and interestingly, the economists tend to agree, I'd like to function, thanks. I'd like to have a productive life, whatever happens, gets strongly prioritised. Issues around suicidality and self-harm scare the wits out of family and carers and are highly prioritised in terms of staying safe. And as any parent would know, the idea of keeping a child safe is an overwhelming one, even if the child themselves or the young person themselves is more reckless in a particular way. Issues related to alcohol and other drugs, again, differentially rated. Physical health. In work I was associated with more than 25 years ago with SANE Australia, the neglected physical health of people with mental health problems was a high priority for families and carers 25 years ago. We have new initiatives only this year about the physical health comorbidity, smoking rates in people with severe mental illness. I wonder if you'd like to comment, Liz, just about the physical health issue and the opportunity to intervene early to change physical health outcomes.
So there's certainly, I think, much more recognition of the physical health difficulties, the high rates of metabolic syndrome, diabetes, cardiovascular disease, smoking-related illnesses in people with established mental illness. What we have been able to identify in young people presenting for care is that you can identify changes in, particularly in their metabolic system, in insulin regulation, much earlier than we had thought, indicating that we need to recognize the risks that people carry, be careful about, be able to provide the appropriate assessment and intervention and take care with medications that may make those syndromes worse. So I think we have the opportunity for earlier intervention, and obviously certainly in obesity we recognize that early intervention is critical. It's much harder when these issues are established. What I find with the young people that I follow up, often their mental health problems become much more stable and much more manageable, but physical health problems, chronic pain, obesity, insulin resistance, metabolic problems, hormonal difficulties become much more of an issue for them as time goes on. And we need to think about those things right from the start of treatment.
Just interesting, last down here, you see the illness type, stage and trajectory rated most highly by guess who? Clinicians. We go on and on and on, and then on some more about, are you the right diagnostic category? Is it the right trajectory? Should we call it this? Should we call it that? Interesting to say, least important to family and carers on an ongoing basis. Next slide.
Better care matters. It saves lives in the short term and provides opportunities in the medium to long term. My family have been cared for over 12 years at the Brain and Mind Centre. My daughter's care and treatment has allowed them to overcome crises and continue their lives with ongoing support. This has provided a pathway that has allowed them to both complete studies, achieve university degrees, and maintain long-term loving relationships. Without access to this care and treatment, there was a very high chance they would not have made it through the years when they were acutely ill and may have succumbed to suicide. I believe this care saved them and that many youth could be saved if they were able to access the same quality care and treatment. Our children deserve to be fully assessed and supported to investigate why their mental health is deteriorating. Specialist multidisciplinary care has helped them to navigate and manage their illness and achieve many goals.
So in my view, that's it. You know, quality care matters. I don't think we should ever apologise for the fact that quality care is the goal. And as it's been demonstrated in cancer care, in infection, in many other areas, access to quality care is correlated with survival. I'm really old now. Some 20 years ago, I said on national outcomes, which deal with cancer, diabetes, heart disease, depression, which was my, of course, favorite thing. And everybody else knew that the distance you lived from quality care determined your outcome. This led in the cancer area to regional centres under the Rudd governments, over $2 billion of new expenditure to take best models of care to where people lived because their lives depended on it. Our view is the same is true in mental health. We need to say so. We need to model it. We need clinicians who are committed to delivering it to work to that particular model. So over the remainder of these particular training seminars, it will be our goal to expand on each of those 7 concepts that I raised earlier on, to bring you further examples from Liz's clinical practice and leadership, from those who've experienced these models of care, so that you too may be able to take these issues forwards with the many young people that you are committed to improving their lives, to be productive, and to achieving the same outcomes as those other young people who are exposed to other severe and life-threatening illnesses. Thank you for your time and attention.